in diabetes field. I'm going to talk about management of type 2 diabetes, what IMPA-MED can add. And let me start with this statement that paradigm in type 2 diabetes management is shifting. Few years ago, we were just concentrating on hemoglobin A1C control. Now we all know that we have to target cardiovascular disease and cardiovascular risk factors and chronic kidney disease, because these are the main causes of morbidity and mortality in diabetic patients. These are the main diabetes complications. We can find macrovascular complications and microvascular complications. Macrovascular complications as cardiovascular disease on the brain and on the heart, and microvascular complications on the nerves, on the kidney, and on the eye. And our aim should be to provide a good quality of life for people living with diabetes. And let me start with the mode of action of Sglt2 in summary. In the proximal tubules of the kidney, we have Sglt2 and Sglt1. And Sglt2, sodium glucose co-transporter 2, is the job of it is to reabsorb the glucose from the proximal tubules of the kidney. It absorbs at least 90% of the glucose in the proximal tubule, and 10% of the glucose is reabsorbed by Sglt1. So the main important of them is the Sglt2. What if we can inhibit this Sglt2 by a sodium glucose co-transporter 2 inhibitor? Then when at least daily 180 gram glucose is filtered by the glomeruli to the kidney, and this amount, 90% of this amount will be reabsorbed by Sglt2 and 10% will be absorbed by Sglt1. If we inhibit this reabsorption, then the glucose will pass into the urine. Mainly, most of the glucose will pass into the urine, leading to osmotic diuresis and leading to lowering of the blood glucose. Let me start with one of the most important Sglt2 inhibitors in the diabetes field, the empagliflozin. And let me start with this question, and please interact with me with the questions. Is empagliflozin a potent antihyperglycemic agent or not? And it is an important antihyperglycemic agent or anti-diabetic agent because it can reduce the hemoglobin A1C, it can reduce the weight, which is an important issue for type 2 diabetic patients because 80% of type 2 diabetic patients are obese, and it also leads to cardiovascular protection and renal protection. In the pooled analysis of many studies done on empagliflozin, placebo-controlled trial, there was change from the baseline up to 0.85 or 0.85% of hemoglobin A1C reduction in different pooled analysis with monotherapy, with metformin, pioglitazone, metformin sulfonylurea, with insulin also. All these data showed there is reduction of hemoglobin A1C up to 0.85%. When empagliflozin was compared with a potent sulfonylurea, which is glimepiride, because glimepiride is considered a potent sulfonylurea and it is used in all non-inferiority studies with new anti-diabetic medications. So when empagliflozin was studied versus glimepiride, it showed non-inferiority in action. It even showed superiority in action, and the hemoglobin A1C reduction in the group receiving empagliflozin was betterly controlled than even the glimepiride. Also, the action was maintained, as you can see, for 2 years. Another study using empagliflozin combination with metformin, and it showed reduction of hemoglobin A1C more than 4.5% of hemoglobin A1C reduction. Let me remind you that these patients, the hemoglobin A1C at baseline was 11.5. They were not controlled. They were severely uncontrolled. So the combination of empagliflozin with metformin reduced the hemoglobin A1C by more than 4.5% reduction. I come now to another question, empagliflozin. Is there benefit for patients on insulin treatment? Can you share me in answering this or not? What do you think? Yes. For example, reducing the insulin dose, insulin requirements. Yes. What else? Weight gain. Yes. Decrease the weight gain due to insulin. What else? Cardiovascular, yes. Okay, it's for all patients. Let me show you these trials. Empagliflozin patients on insulin. The glycemic control is better in the group received empagliflozin, whether 10 milligram or 25 milligram, and this was the conclusion. Empagliflozin for 78 weeks added to basal insulin improved glycemic control with similar risk of hypoglycemia to placebo. There was no increased risk for hypoglycemia using empagliflozin 10 or 25 milligram. Another data from the trial, the weight effect, we can see here that the group received empagliflozin 10 milligram and 25 milligram had lower weight, and it reduced weight up to 2 kilograms in the group receiving empagliflozin versus those on basal insulin alone. The change in insulin dose, as you mentioned, the patients on insulin alone, gradually, they require increasing the dose of insulin. While in those receiving empagliflozin, whether 10 milligram or 25 milligram, they didn't increase the dose of insulin, and this was the conclusion. Empagliflozin for 78 weeks added to basal insulin improved glycemic control with lower insulin requirements and with a similar risk of hypoglycemia to placebo. Another question, is there an added benefit of weight reduction or not? And you said yes. And this was the data for the pooled trials on empagliflozin. There was reduction of weight more than 2 kilograms in all of these studies done. But actually in your practice, did you notice more weight reduction with empagliflozin? Yes, especially in the first like 6 hours or 2 months. This from the experience. Can we share the experience with some of you, please? Yes, Dr. سيد. إيه رأيك؟ أنا دايما 6 كيلو دي عندي صراحة، فمستغربة إنها مش طالعة في الداتا ليه؟ الريل واي دكتور حسام عشان بيقرا كتير. gain.
ممكن توصل ل 4 و5 كيلو في اول 6 شهور.
البراكتس الحقيقه بيدي نتائج اكتر. دكاتره من ليبيا، ايه رايكم في الاستخدام؟ عندكم ايمباجليفلوزين؟ اتفضلي.
especially if it's combined with other agent. I think the synergetic effect of the empagliflozin with other anti-diabetic agent is more than its effect while it's alone.
Thank you. دكاترة 4 6 كيلو دكتور. طبعا ده أكيد. والله هي ابتدت تقل أكيد. أيوة تمام. دكتور أسامة the same. And let me come back to this trial again, empagliflozin versus glimepiride. And the glimepiride is a wonderful sulfonylurea, but it causes increase in weight like all sulfonylurea. And here in this trial, there was increased weight in glimepiride, about 1.7 kilograms. But empagliflozin was accompanied with reduction of weight. So the comparison is 4.7 kilograms less in the group receiving empagliflozin versus those receiving glimepiride. Coming to this important question, does Sglt2 inhibitor empagliflozin offer a unique cardiac protection or not? رأي حضراتكم؟ Yes. طيب خلينا نقول statement مهمة جدا. Life expectancy is reduced in diabetic patients around 6 years. This is known from statistics. And diabetics with myocardial infarction lose 12 years of their life. So we need to target cardiovascular risk factors in diabetic patients. Now the Empirical trial, one of the most important cardiovascular trials in diabetes field, and it was really a breakthrough trial in type 2 diabetes, and this is a trial of empagliflozin cardiovascular outcomes and mortality in type 2 diabetes, and it was done in 590 centers in 42 countries. And this is the outcomes of the Empirical trial, primary outcomes, secondary outcomes. The primary outcomes are the 3-point MACEs, time to first occurrence of cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke. And the key secondary outcome were the 3-point MACEs with added hospitalization for unstable angina. And the other outcomes were all-cause mortality or hospitalization of heart failure. This is the arms of Empirical trial. There was a placebo arm, and one arm was empagliflozin 10 milligram, and another arm was empagliflozin 25 milligram. This is the outcome. 14% reduction in 3-point MACEs, 38% reduction in cardiovascular deaths, 35% reduction in heart failure hospitalization, and 32% reduction in all-cause mortality. So this is really a breakthrough in cardiovascular protection in diabetic patients. And this was the figure for lowering the 3-point MACEs, 14%. And how do these Sglt2 inhibitors protect the heart? There is proposed mechanism. لو بصينا هنا الحقيقة التيبل دي كبيرة جدا، مليانة ميكانيزمز كتيرة جدا. خلينا نتكلم على either glycosuria or natriuresis. For glycosuria, there is improvement in hemoglobin A1C, reduced inflammation, reduced glucose toxicity, leading to cardiac and renal protection, negative caloric balance, leading to weight loss, reduction in epicardial fat, improvement in cardiac contractility, improvement in inflammation and fibrosis of the heart. All of these mechanisms will lead to cardiac and renal protection. Again, uricosuriya, which is a very important protective mechanism, decreased plasma uric acid, decreased atherosclerosis, again cardiac and renal protection. And to the right side, decreased blood pressure, decreased arterial stiffness, and decreased intramolecular hypertension and hyperfiltration, decreased plasma volume, decreased ventricular arrhythmia. All of these are now proved, and all of these mechanisms will lead to cardiac and renal protection. And this is a comparison between the three molecules, empagliflozin, canagliflozin, and dapagliflozin, in the main cardiovascular outcome trials, the Empiric, the Canvas, and the Declare trial. For the 3-point MACEs, they found that 14% reduction in empagliflozin and 14% reduction in canagliflozin, and it was non-significant for dapagliflozin. For cardiovascular deaths, reduction of 38% of cardiovascular deaths in empagliflozin, and it was non-significant in the remaining two molecules. For hospitalization of heart failure, reduction of 35% in empagliflozin, 33% in cana, and 27% in DAPA. For kidney outcomes, reduction of 39% in empagliflozin, 40% in canagliflozin, and 24% in dapagliflozin. This is a clear comparison between the molecules. All the molecules are beneficial, but everyone has its powerful points. I come now to this important question: is there a role for Sglt inhibitors in renal protection or not? Yes, and this is the data. Reduction of 39% in the new onset of worsening nephropathy, reduction of 38% in new onset of macroalbuminuria, doubling of serum creatinine will be reduced in 44% of cases, and renal replacement therapy will be reduced 48% in patients using empagliflozin. And this is a proposed mechanism for inhibition of renal disease or chronic kidney disease with SGLT2 inhibitors, and the main of them is reduction of the glomerular pressure due to afferent vasoconstriction, afferent arterial vasoconstriction, and reduction in glomerular hyperfiltration. There are many mechanisms, but this is the most important mechanism, and it is shown here by the electron microscopy. To the left, before the medication with empagliflozin, and to the right, you can find the afferent arteriole constricted. So this is the main and most important mechanism of renal protection in patients using empagliflozin. I come now to an important question, another important question. What is the positioning of SGLT2 inhibitors in ADA 2021 guidelines? And this is a statement from ADA. The patient-centered approach should be used to guide the choice of pharmacological agent. Whether the patient has a fear of hypoglycemia, fear of weight gain, the price also is an important issue. If the patient is having cardiovascular or renal risk factors or renal disease, other side effects or risk factors, and of course the patient preference. العيان بيفضل إيه؟ لأن دي حاجة مهمة جدا. And this is again the statement, and among patients with type 2 diabetes with established atherosclerotic cardiovascular disease or indicators of high risk of established kidney disease or heart failure, we should use an SGLT2 inhibitor or GLP-1 receptor agonist with demonstrated cardiovascular benefit is recommended. As a part of the glucose lowering medications, in spite of the hemoglobin A1C. يعني أنا ماليش دعوة بالهيموجلوبين A1C قوي إذا كان البيشنت عنده cardiovascular disease or at risk for cardiovascular disease or having risk for chronic kidney disease. إن أنا لازم أستخدم دواء بس بشرط إن يكون ليه proven efficacy in this point. ودي الحقيقة ال AGA 2021. معلش اديني دقيقتين بالظبط بعد إذنك. وخلينا نقول هنا أول حاجة إمتى بنستخدم ال Sglt2 inhibitors in patients with atherosclerotic cardiovascular disease or indicators of atherosclerotic cardiovascular disease, patients with heart failure, patients with CKD and albuminuria, in patients who have the need to minimize hypoglycemia, and in patients wishing to weight loss, and also in combination with other medications whenever necessary. Again, this is the AGA, and let me give you a more clear slide about the Sglt2 inhibitors. They have an intermediate efficacy. When added to metformin, the efficacy is higher, too much higher. No hypoglycemia. They will lead to weight loss. The cardiovascular effects on atherosclerotic cardiovascular disease, the benefit is in empagliflozin and canagliflozin, and on heart failure, the benefit is on impacana and DAPA. And for progression to chronic kidney disease, the benefit is cana, impa, and DAPA. How to use empagliflozin in clinical practice? إيه رأي حضراتكم؟ استخدمه امتى؟ ايه الحالات؟ طيب. For all patients except for contraindication. طيب ماشي. خليني انهي بالسلايد دي. Sglt2 inhibitors meeting unmet needs in diabetes care. زي ما حضراتكم شايفين ان احنا they promote weight loss, renal protection, no hypoglycemia. It complements the action of other antidiabetic agents and improvement in glucose and weight support, other cardiovascular disease, and it improves glycemic control. شكرا لحضراتكم.